Well, Karen, I thank you and Eric and the rest of the organizers for having me here. I'm from, like Scott and White, from a rural healthcare system. This is the valley in which our little hospital sits, a town of 4,000 people with a 430-bed hospital that's the center of now a 9-hospital, $4 billion a year group. So thanks for having me here. It looks like we started with physics. Now we're doing a little bit of math, it looks like. And this really, a lot of this work belongs to Nick Marco, a little bit to Bob Weil, one of my old friends and partners from Vandy Cleveland Clinic. I've now recruited him to Geisinger as well. I'm talking a little bit about taking a little different step of how we interact with our patients with the limited amount of data we have, so that we can move toward that era of personalized healthcare. And it doesn't just mean knowing all the genomics and epigenomics, proteomics of our patients, but how do we personalize our decision making? And my disclosures, I work on a couple of strategic advisory committees, Novacure, you've heard a little bit about already today, and Medtronic. We don't need to talk about this, but I'm here as one of the barbarians who goes in, along with Dr. Brem and Soren, who's in the back getting his coffee, much needed, that goes in and destroys people's brains to carve out these horrible weeds that are growing in there. We all know about the treatment of glioblastoma, so I can move through that. And most of this group knows about the prognostic factors that we used early on to start this mathematical model that Nick worked on. And Nick is one of my former residents from Cleveland Clinic. He won the Van Wagenen Fellowship. And unlike most neurosurgeons who are interested in oncology, instead of going off and studying molecular biology, he went to Cambridge and studied applied mathematics for a year before doing his fellowship. And Nick is a brilliant young mathematician and surgeon. So what he did was looked at some of our most common things. We have good data, and he used the MD Anderson database of 713 glioblastomas that, of course, had good data on age, Karnofsky, percent resection, as Ray Sawai has been interested in that for a long time. Molecular markers we didn't have much data on, so unfortunately they have not been modeled yet. Radiation therapy and temozolomide, all the things we see and do on all of our patients. In the current era, our treatment's pretty standard at the start. It's not that it's great, but it's pretty standard because we don't have a lot of things that work. It's a part of Karen's frustration. All of us, I've been working in this field 25 years now. Can't compare to Dr. Brem's long era of work in the field, but things have been depressing for a long time. They haven't changed very much since I started, and we still have pretty easy decisions about something like this. You send in the barbarians to carve out a portion of this person's right temporal lobe, and we've made a lot of advances. One of my mentors, Gene Barnett, with stereotaxy, Ray Sawai and all his work, so that we can go in and carve out something like this, have a patient be normal and out of the hospital in 2 or 3 days with a big hole in their head and no obvious tumor left behind. But that one's easy. That's an easy one to think about. Now, again, one of my old partners, a year behind me in fellowship when I was down at Anderson, was Michel Lacroix, and along with the folks at Anderson about 13 years ago, published this paper in Journal of Neurosurgery that was the first to really look at how the barbarians among us impact survival. And what they had come up with was that they seemed to show that there was a threshold, using fairly simple mathematics, that there was a dichotomy between those who had greater than 98% resection and those with less. And the survival increased from about 8 to 13 months. More recently, Mitch Berger and his team at UCSF have a huge, immense database they've been collecting in Mitch's era there, and have now done it for low, mid, and high grades, looking at percent resection, and they found a bit of a threshold effect as well. The monograph from UCSF suggests that as low as maybe 75, 78% resection had a survival benefit over biopsy alone, and that there were some incremental increases as you got closer to a gross total or imaging complete resection. So it was in this environment that Nick really started to think about it. He thought these are very primitive mathematical models. What should we do? And this is something Nick had talked about with Dr. Weil when they were both back at Cleveland, myself while I was at Anderson, in order to evaluate and said, you've got a great set of databases between what Gene has collected in Cleveland and what Ray has collected down at Anderson. Why don't we start analyzing it and see if you can develop a better model? This turned into papers last year in Journal of Clinical Oncology with Nick, Bob, and of course Ray is the senior author there, and then these two add-ons at Yahoo who Yahoo's Ed Geisinger, who did the editorial for it. So what we really want to know is not what we do for the relatively straightforward ones here, but this case that I had 2 weeks ago. You know, it's a little more subtle here. We've got something going on in the thalamus, and we'll talk more about this patient later on. What do we do with these complex patients that surgery is a high risk? In this case, we had a 63-year-old who had a KPS of 90. Her minimal symptoms resolved pretty well on steroid, and at another facility nearby, she had a needle biopsy because she had trapped ventricles, shunt placed. And they was told the tumor was unresectable and to go ahead and start on therapy when she came to us for a second opinion. So here you can see the biopsy tract coming down, this rather large thalamic tumor. You know, we've got prettier colors, I think, than Steve's tractography, not just green and yellow. You can see the corpus callosum rising above, the corticospinal tracts coming down by the side, going into the midbrain and pons. What do you do with this thing? Can you take it out? Should you take it out? Or were her outside folks correct? We should leave it alone. And that's really where the kind of question and problem we had that intrigued myself, Bob, and Nick, and really got him started on this. So I'll try and go through I've eliminated, Nick's initial slide deck for this was about 80 or 100 slides. That was so math heavy, I thought we'd probably get cortical injuries here from people passing out and bumping their heads on the desk. So I've tried to simplify it and take it down to what mere mortals can understand about the mathematics. So forgive me if it gets a little complex, but trust me, I've eliminated the worst of it. So what did he do in modeling this? It's all about preparing the data, selecting the model that works best for you, optimizing the model, and then validating. First you build up a test model, and this is the same type of thing that's done in large genomic and proteomic work. You build up a test model of those genes that are worthwhile. Here we're testing these variables, and then you internally validate that model, and then you need an external or a trial database to check, and then try and apply it clinically. He loves his data, trust me. Nick has been with me for 2 years now. He's already the chief data officer for the entire Geisinger health system, runs our data warehouse, has a group of Lithuanian, Estonian mathematicians working in there and computer modeling folks. So he loves his data, trust me. So these are the type of things he had to think about as he's trying to put his model together. Are these things linear? Are they dichotomous variables? How do we put them together? What's the quality of the data? Can we use? And that's why he decided to start validating this model just with the simplest thing. Our intent is to later go on and make this model more robust as we move forward. And here is the type of data that was available in the MD Anderson tumor set. It does have data about steroids that we need to go back to, pre- and post-operative enhancement, percent resection, location, and this database has been up and running with Ray for about 18 or 20 years now. It's had 713 tumors that were usable in this. Now, typically in medicine, we use Cox proportional analyses to look at our modeling and our survival data. And after his year at Cambridge, Nick said, that's not really the best way to look at data like this. It's non-parametric data. We do know that its survival is a known distribution. We know what the hazard is. We really want to look at survival time and assume that the hazard rate, risk of dying, is a relative constant as opposed to assuming the hazard ratio is constant. So use this ATF model with a log transformation of the survival benefit. Trust me, as I said, we could go, if this were a group of mathematicians, they could argue this for hours on end, but trust me that I'll say we'll have to trust Nick and his math here. So here's how the data fit. Each of these lines are lines on survival from the MD Anderson survival curve. The curved line is the mathematical modeling, and you see it relatively closely applies to this. Here is the survival curve in this way, and if you try and make an R-squared function out of this, you can see here's the line where a perfect fit would be, and here are our data points fitting nicely along the line with a log logistic distribution. So we thought this type of modeling with the ATF model would probably work as well as anything we could, and it gave us the best mathematical model to start looking at this data. So for all those folks who love equations, here we have just a few of them. And how we got down to the survival equations here. So I won't bore you too much with the math, but saying here are the coefficients and the slopes that were finally used, and the equation to be solved is right down here. And you'll notice that, you might think that radiation has a big impact. Remember, this is a 0 or 1 for radiation. They had it or they didn't. You don't get partial credit. So they get radiation clearly has a pretty big effect here. It's 0.3 of an effect. Temozolomide, yes or no, almost 0.5. Age, 0 to 100 almost. So if you apply that out, age has a similar effect, as to radiation from temozolomide. The log of the Karnofsky, so it's going to be between 0 and 1. Again, you'd think it'd have a big effect, but again, it's very comparable to the age effect. But here are the barbarians again. The extent of resection, is going to vary from 0 to 1 as well, but it's got the biggest number after it. So extent of resection, as you'll see in these models, does turn out to be the biggest variable of what we look at here. Not by a huge amount, but it does show that at least for the foreseeable future, Soren, Dr. Brem, and I have a future for now. We'll still have work to do. After he internally validated, predicted survival by this model was 10.9 months, actual overall survival 11.5, and it took up most of the difference, all but about 7+% of the difference. So once we have this model, what we essentially do is can generate curves for any individual, any age, any Karnofsky, any treatment modality on this, that we can sit down with the patient and start to talk with them about what has been done and what should we do to help them out. So our first application of using this is personalized prospective survival forecasting. And we actually use this model in our tumor boards these days on many of our complex patients. So I'll give you a link at the end of this that all of you can use it in your tumor boards as well in trying to help with complex cases. So here's a question that I'm sure Dr. Wong has seen. My daughter's getting married in 9 months. Am I going to make it? What can we do to get there? Patients always have a goal in mind. So for this particular patient, we plug in her Karnofsky, her age, her percent resection, generate a survival curve. Here's the red lines are the upper and lower 95% confidence intervals of her survival curve. The black line is her median survival curve. So you tell this patient, what does 9 months mean? Well, you've got between a 67 and 77% of making it 9 months. So she's got some idea of how to plan. Your physicians have some idea of what we need to do to try and maximize that chance for her. So you can take an individualized point estimate, reduce the model, and give a personalized survival curve estimate for the patient. Another question we get fairly commonly is, especially in our rural part of the state of Pennsylvania that we take care of, is it's a big hassle. A lot of these people have to travel an hour away each day just to get their radiation, or come stay for the week to get their radiation, go home on weekends, almost like when they come down, when I send them down to the proton beam down at Penn. They can't come back and forth. So should I even bother to do this? Does it make a difference? So again, you can add in the incremental survival benefits of all these different therapies for patients. So here's one patient. She's 84 years old, Karnofsky's 60. Amazingly, despite that, had an aggressive resection, got 98% of it out, just a small amount of and this is by the enhancing tumor, by the way, not by the Flair or Raynaud criteria. So what happens if we give temozolomide only? Well, her survival curve over here would expect, on the red temozolomide curve, 210 days of survival. We add the radiation plus temozolomide, you get another 70 days. What does that mean? About 10 weeks, but 6 of that are going to be spent traveling back and forth. So for each individual patient, is that time worth it for her? Now we go to another patient, a younger patient, good Karnofsky, similar extent of resection. Survival curves are very different here for this patient. 500 days with temozolomide alone, 200. So 29 weeks, you're getting almost 7 months out of this, of which a month and a half or 2 are spent during the radiation. Much bigger survival benefit for this. And you can see how that's going to influence patient decision-making, how it's going to influence your counseling with these patients. And we have ones like this. This is not the one that I operate on, but one of Nick's patients from a little while ago. Is it going to make a difference if I can only, doing a needle biopsy versus maybe getting in here and with good subcortical monitoring, maybe I can get 70-75%. I don't think we're going to be able to push it beyond that, because if I had all the pictures to show you, there's a little bit of bilateral tumor. You're probably not going to get some in the septum. Does it make a difference? So again, we can sit down as surgeons now and start to estimate how our percent of resection influences the survival. And here's a typical survival curve for a 64-year-old very similar to the one I was doing, the 63-year-old with a KPS of 90. Here's a typical survival curve for that patient with the extent of resection coming along the bottom. Biopsy only, it might average about 140, 150 days. With imaging complete resection, you're up to about 410 days. Quite a bit of improvement. These curves diverge quite a bit depending upon the patient. And here's some, again, modeled for an elderly ill patient, a middle-aged patient, and a younger, healthier patient. As you see, we barbarians do better on young, healthy patients. So do our chemotherapy, so do our radiation doctors. Young, healthy patients, we know. Is it the immune system? We've seen some pretty compelling data on that, and there'll be some interesting data over at the main meeting about that as well. We have less effect on adding to the surgical resection as patients age. So in general, this provides, instead of finding that there's a plateau and then a sudden jump in survival, it's not as dichotomous as the older studies that suggest, that there's a parametric parameter that comes in that's not exactly linear, that correlates with our survival and how much we get out. And it suggests that we should probably push for the maximal safe resection as opposed to the older image of all or nothing, or nearly all or nothing, that some of the older papers had suggested. So back to our patient that we had again. Do we do a biopsy or a subtotal resection? Again, for a young patient, here modeling, we got 5% out of the biopsy versus, say, 75%. Big difference, 280 days. There you're looking at 9, almost 10 months out of that. You take your older patient, putting them through that risk may not be as worthwhile. We're only looking at 3.5, 4 months there. And remember, these are the mean benefits. We can also look at the minimum expected benefits to this because we have confidence intervals on this. So you can tell your patients what your maximum benefit might be, your median benefit, and your minimum benefit. So it doesn't say, because of course for every patient, they survive to a certain day, either 0 or 1. They don't get 100 chances at it. So they don't get to average their mean survivals on this. And it doesn't tell you exactly what to do, but it does give you a lot more meaningful data to have these discussions with your patients. So here's one, again, we as surgeons face all the time. The deep part of the tumor, like these thalamic tumors we said, come very close to some critical fibers. Is it worth it to go after that? Because we do know, there's been great data out there, that if we injure someone, their Karnofsky drops, their survival drops markedly. So even though we may think we're doing the right thing, if we turn them from a Karnofsky 100 to a Karnofsky 60 or 30 or 40, we have a hugely negative impact on their survival, even though we're trying to help. So here's some minimal increments. Suppose we go from a 90, 92% to a 98% resection. Again, much bigger difference, and I didn't fix that, on our younger patients, maybe 50 days versus 20 days here. So again, younger, healthier patients, it may, when you're getting to that critical decision making, every little bit matters a little bit more on those patients on this model. So it gives you, again, that perspective that we want to go for maximum safe as opposed to the resection threshold paradigm, and we can make some quantitative differences, not just qualitative differences, when we're having these tough discussions with our patients about the risk benefits and alternatives to surgery when we do our consenting. We can also understand the relationship between combining the therapies now. If we can look at these curves all together to say, where does XRT, surgery alone, XRT alone, temozolomide alone, or the combination do for the patient, and really start to model as what the change in the extent of resection will do, what the benefit of adding the temozolomide may do for an individual patient. And, again, not a binary thing. When I started with Gene as a junior resident back at Cleveland Clinic, he'd say, radiation adds 3 months, or the chemotherapy adds 3 months, or surgery adds 3 months. So they get 3 months if we don't do anything, 3 months for each of the things we do, they get about a year. It's not binary, it is changing, and we'll be able to model this better as we can incorporate more molecular data into the model. So in summary, this model gives us a log logistic, accelerated failure time model to give us some data that we can use in everyday discussions with our patients and their families. At this point, the model is just on age, the log of the Karnofsky, extended resection, and whether XRT or temozolomide have given. And they've been validated internally and externally with Cleveland Clinic data of about 200 glioblastomas out of that database. So now we have all this data, and we're back to my patient from 2 weeks ago. What do we do with this? Is it worth it to do? And again, as we're sitting down having that consent discussion with the patient, what do we talk about? The chance of neurologic injury. Here we were talking about TTF earlier. Can we add TTF? Well, no, not with a shunt in. We're not allowed to at this point because of potential changes in the field. So we talked about, could we... They still have no shunts at all in their exclusion criteria. It doesn't make much sense to me as well. So one of the things we talked about, because she was already bilateral, wasn't eligible for Linda Liao's trial that we have over the DC-VAX trial because she was bilateral. Could we make her eligible for the TTF trial or TTF treatment in general? And what are the other clinical trials available both regionally and nationally that we should go through? She was relatively young. 63 is getting increasingly younger for me as the years go by. And she just had a biopsy, with a minimal amount of that tumor taken out, 1 or 2%. Her survival then, even with everything, was suggested to only be a few months, 4 or 5 months. But nears, 14 months or so with trying to get a near complete resection. So what should we do? Well, she had, unfortunately, had a family member and a close friend who had recently gone through glioblastoma and wanted something aggressively done. It was not for everybody, but it was for her. So what I did was I got the rest of the barbarians and then some bright people, neurologists or intraoperative monitoring folks, to keep me out of trouble. And that's who I really rely on because, as a barbarian, I'm just going to go rampaging through this, corticospinal tracts be damned. But what we did was take an interhemispheric approach down on this tumor. We came across, took about the middle third or so of the corpus callosum, opened that up to get into the tumor, and dug this out of the ventricle, came right down to the internal cerebral veins, worked our way from inside out on this tumor. I know Gene would hate that, but in this case we sort of had to. Couldn't exactly go around this en bloc for Gene or Ray's benefit. And we're able to get all but this tiny little, this is the worst part left, this tiny little bit of enhancement. As we got to parts out here and then down here, we got stimulation with our intraoperative neurophysiology, where I take one of my Penfield dissectors and I attach a little alligator clip and run some electric current through it, so it's a monopolar stimulator. We got down to about 8 milliamps of stimulation here, suggesting we were right up within a couple millimeters of the descending tracks. That's about my tolerance for being bold. And as you see, did a reasonably good job. She woke up, did very well, woke up immediately, went off to rehab, has a little bit of residual weakness that's recovering rapidly 2 weeks post-op, and I think is going to do very well and hopefully have not hurt her too much. So in summary, what can we do with data like this? And I said, this is just the start. Like the TT fields are just the start of potentially a new paradigm in cancer treatment. We think this type of mathematical modeling will give us a new way to interact with our patients, and we hope to make this model much more robust with increasing biologic data as we go on. But we can produce personalized probabilistic survival curves. We can give incremental survival benefits for adjuvant therapies. Again, should be able to add bevacizumab data as that data becomes more robust, IDH1, MGMT data, TTF data, make predictions on the extent of resection and what relationship that has to survival as well. So again, this analysis supports a maximal safe resection, but the main benefit I find as a clinician is that you can have a much more knowledgeable discussion with your patient and not just go on your gestalt, your gut, what you've seen in your own clinical practice. We want to be able to validate this model with larger databases at other hospitals because obviously surgeon-specific data is going to be even a little bit better for patients, and we can, just like as we get N2QOD up and running, the National Neurosurgical Quality Outcomes Database, we will soon have more robust data, just like my dad had before he underwent cardiac surgery, that would say, with these risk factors, here's your risk of morbidity and mortality, your average hospital stay. We need that data in discussing it with our patients. And it's going to give us extra ways that we can have patients participate more in their decision making and hopefully give us better mathematical models for understanding what we do is really helpful to our patients. So again, what are the limitations? The quality of the data is small here. It's only been tested with the Cleveland Clinic and MD Anderson data thus far. It lacks the molecular data. It's preoperative. And multi-center database may be different, institution-specific or surgeon-specific may be different as well. nickmarcolab.com is where you can find this model. It's not quite as pretty, but if anybody wants to use it, just go to Nick's lab site. There are models there for using this in your personal data. You can pull it up while you're sitting at your computer next to your Epic or whatever electronic health record you have as you're going through this. We're soon going to have quality-adjusted data, quality-adjusted life year data, and cost data available shortly. We're hoping to have that in the next couple of months, and then, of course, hoping to incorporate more molecular data as time comes on. So I thank you all for your time and listening to a boring math lecture in the midst of this day, but hopefully some of you will find that intriguing. So thank you.